like to know about anaesthesia for caesarean sections, and this was met with total and utter stunned silence, which left me with the conclusion that either they knew everything there is to know already about anaesthesia for caesarean section, which, to be fair, isn't a huge amount, or they were just completely disinterested with it. I'm not sure which. Hopefully not the latter. Let me just see if this pointer works, because I have to use the pointer so the remote room can see. So, yes, I work at Tunbridge Wells Hospital, which is that's a picture of it. It's a new PFI hospital, which is very nice, but bankrupted us, as they all do. What's the big deal here? So we've got two options, really, haven't we? And I'd say it's not that complicated. In broad brushstrokes, we've only got a couple of options to provide anaesthesia for caesarean sections. Number one is our good old-fashioned general anaesthetic, and number two is some sort of regional anaesthetic. Now, you might think, well, what's the big deal about general anaesthesia? You're an anaesthetist. For the vast majority of surgical specialties, that's your mainstay. You provide general anaesthesia all the time. So, what's the big fuss? Why is it such a big deal these days when we have to resort to general anaesthesia? And should it be a big deal? And there's a number of pretty good answers to that question. Because this is a larynx. This is what we hope to see when we put someone off to sleep and put a laryngoscope in their mouth and have a look down. Anyone name this structure here? What's that? Epiglottis, excellent, yeah. These white things here in the middle? Vocal cords, exactly. So if you can see those things, then you're happy. Two white vocal cords with a dark hole beneath them. Pass the tube through there. Problem solved, no problem. You're away and you're safe. Now, maternal physiological adaptation to pregnancy is a remarkable thing, and it's fantastic for preparing a mother for delivery of a baby. But unfortunately, most of the aspects of it work against us, us as anaesthetists, when it comes to providing anaesthesia. Because what happens is, when you look down, your direct laryngoscopy, when you look down, and it's not quite as nice there, is it? It's all a bit swollen, the structures aren't as well defined, and that's still a pretty nice view and pretty easy to see. But sometimes what happens if you look down and you can't see anything at all? So that's number one of the problems, certainly in the past, that have been related to general anaesthesia in caesarean sections, is that there are a number of reasons why it can be harder to safely pass a tube into the trachea in a pregnant woman. And in fact, the sort of quoted numbers are that it's 10 times as frequent that you'll find an unexpected difficult intubation. And when you do, and you can't pass a tube, and you're in a hurry anyway because there's a baby in distress, that can lead to some fairly stressful and sometimes dangerous situations. So there's reason number one why general anaesthesia can be problematic. There are some sort of other reasons why general anaesthesia can be problematic, and this is one which will be familiar to many of us. I'm sure it's probably a nationwide phenomenon that we all encounter more and more and more high BMI patients. And I don't know about you, but I've certainly noticed since I qualified as a doctor, and certainly since I became an anaesthetist, that the BMI numbers that are making people sort of take a deep breath are increasing. So it used to be that the BMI of 40 and everyone would be getting a bit anxious, and now BMI 40s are 10 a penny, and it's the BMI 50s and 60s are starting to cause some consternation. But the fact is that having high BMI, there's good evidence that having high BMI leads to a number of increases the likelihood of obstetric intervention, of complicated labour and delivery, and of complications related to anaesthesia. And that's on top of the other physiological changes that occur in all pregnant patients. So obesity is another issue for us as obstetric anaesthetists. Now, I mentioned the physiological changes and other aspects that can lead to difficulties with providing general anaesthesia, and these are just a few of the ideas. Delivery suites and obstetric theatres are often in remote locations. Seldom are they co-located with the rest of the theatre complex and the extra staffing and assistance that brings. And also, historically, it's always been the most junior anaesthetist that was dispatched to the delivery suite with little or not much training in the past in terms of providing anaesthesia full stop, let alone the complexities of obstetric anaesthesia. The second picture over of the blue lips is an indication that the adaptations of pregnancy mean that maternal oxygen demands are much higher. Pregnant women use oxygen at a much higher rate because they're more metabolically active and because they've got a fetus that is metabolically active. This takes away another of our sort of safety features. In a non-pregnant, healthy person who's been breathing oxygen, they can be apneic for minutes without desaturation. But as many of you will have seen, seconds of apnea in pregnant patients can lead to quite significant desaturation, mother and the baby. Thirdly, and I don't know if this occurs to many obstetricians, but obstetric anaesthesia is the only area of anaesthesia that we encounter where frequently the surgeon requesting anaesthesia wants the patient anaesthetised 5 minutes ago. And so we're under significant time pressures within obstetric anaesthesia. And we're also dealing with present partners, with anxious mums, and with teams that are looking after them that are very anxious to stage an operative intervention in the interest of either mum or baby. And that further adds to the potential for problems and mistakes. One of the other physiological adaptations that you'll all be familiar with is certainly the midwives among us will frequently be looking after mums who are complaining of heartburn left, right and centre. And we all know that there are several changes in gastrointestinal physiology that can lead to problems for us. And those are that the stomach empties more slowly, therefore it's likely to have more contents, that the contents will have a lower pH, and that the lower esophageal sphincter at the bottom of the esophagus, which normally contains your stomach contents in your esophagus, is likely to be lax under the influence of pregnancy hormones, leading to the increased chance of regurgitation of gastric contents and sometimes, if not properly managed, aspiration of those gastric contents into the lungs, which can be serious or even life-threatening. Anyway, that's all the negative things, or many of the negative aspects of maternal physiology related to general anaesthesia. As we know, we've had a long history in the UK of confidential inquiries into maternal deaths, and I know that you had a talk from Marion Knight earlier about its current incarnation, Embrace. Now, the first confidential, does anyone know when the first confidential inquiry was published? Any ideas? Decade? 50s. 1952 is the first confidential inquiry. And if we look at maternal mortality per maternity, per 100,000 maternities, over a prolonged period, we can see that on the left of our screen we've got going from 1840 down to the current time. Something happened in the late 1930s, early 1940s. Now, lots of you hopefully will be familiar with this slide, but anyone got any good ideas on what happened during this period to significantly reduce maternal mortality? Oh, sorry, can't hear. Yes, excellent answers. Yes, so, well, they're two good answers. So blood transfusion managing hemorrhage, yes. The beginning of antimicrobial agents, probably sulfonamides in the first instance. But we always, in our sort of slightly medical healthcare vanity, we think about the specific things that we do. But what's more likely to create that sort of drop in mortality? Public health measures. So this was a period of increased sanitation, maternal health, and provision of healthcare. Now, what nobody said, of course, and I'm glad they didn't say it was anything to do with anaesthesia. It's absolutely nothing to do with anaesthesia whatsoever. But if we look at the small box in the top right-hand side, that is maternal death, direct maternal death due to anaesthesia taken out. And we can see that we're only talking, even at its worst in the 70s, about 1.4 per 100,000 maternities. But at that time, that was the third most common cause of direct maternal deaths, which is a position that we didn't want to be in. So what's happened during that time to reduce the number of deaths This is about anaesthesia now, so no, not legalisation of abortion, no. So anything to do with anaesthesia, any ideas? Regional anaesthesia, well, you... Sorry, I'm breaking the place. I think it'll still work. Thank you very much. You could be tempted to think that the advance of regional anaesthesia could be responsible for that. However, don't forget that during that period, the incidence of caesarean section has also gone up and up and up and up and up and up. So we're actually providing probably more general anaesthetics than we did at that time these days, with lower maternal mortality. So, yeah, could be something to do with regional anaesthesia. It could be to do with the fact we're getting better at providing general anaesthesia. But probably it's similar to the previous question. It's more likely to be a global improvement in training and provision of services in general, both in obstetrics and anaesthesia, that's leading to these effects. And you can see that now we've been, since the late 90s, we've been bumping along at less than 0.2 per 100,000 maternities, which is comparable to other Western European countries. Okay, so Kirsty's already mentioned the requirements for regional anaesthesia for caesarean section. She's also mentioned it's necessary to anaesthetise the uterus. It's necessary to numb from T10 down. And that's okay for labour analgesia, but if we're thinking about surgical anaesthesia, we're going to have to aim a little higher, because it's not just the uterus that we're dealing with. There are other visceral structures when we're doing an operation that we're going to need to anaesthetise. And some of those have innervated by sympathetic outflow from higher thoracic nerve roots. So we're probably going to have to aim for a roundabout T4, the fourth thoracic vertebraspinal level, to achieve satisfactory analgesia for our regional anaesthesia for caesarean sections. And in order to do that, Kirsty's already touched on some of these things, but it's worth just reminding ourselves of the relevant neuroanatomy, because it's easy to let it slip your mind. So we've got 3 layers of meninges, haven't we, surrounding our spinal cord. The outer layer, in green here, is the dura mater. The one below it, sorry, my arrow is a bit sensitive, which is closely adherent to it, and to all intents and purposes, they provide a single layer, is the arachnoid mater. And the third layer, which is closely adherent to brain and spinal cord, is the pia mater. Now, pia is fairly irrelevant with regard to provision of anaesthesia, but the other 2 layers aren't. So if we're thinking about doing an epidural, which is an awkward terminology, it probably should better be called an extradural, because we're intending to place a plastic tube outside this outermost layer. And we're going to pass a fairly large volume of local anaesthetic through there. And the local anaesthetic is going to slosh all around the outside of the spinal cord, and it's going to act on the spinal nerve roots as they pierce the meninges. So you need a large volume, and it's working on nerve roots. And it's because of that, it takes a while to work. A spinal anaesthetic, on the other hand, is where we deliberately pierce these 2 outer layers of meninges. We pass our needle straight into this space here, the subarachnoid space, which is full of CSF, cerebrospinal fluid. Now, that obviously gives us a much more definitive endpoint, because you hopefully pass your needle until you get a pop and you get a nice, clear CSF coming back through your needle. And you place a small volume of local anaesthetic in there, so half a teaspoon of local anaesthetic compared with the 2.5 mils compared with 15 to 20 mils when you're using an epidural. And you can see that the local anaesthetic is going to work directly on the spinal cord and the cauda equina, the nerve roots that are passing through the end of the spinal canal. Much faster, a bit more reliable endpoint, and a bit more reliable in terms of surgical, clear on those anatomical aspects. So when we're thinking about how are we going to achieve those things, if we're thinking first about a spinal, other names being subarachnoid block, as we've discussed, that's because of the relevant neuroanatomy, or SAB, we need to use a needle to pierce the dura. But we know what happens when we pierce the dura is we tend to get a leak of spinal fluid, which leads to our headache complications of analgesia and anaesthesia. Now, fortunately, well, the worst, if you pierce the dura with a great big needle which has got sharp edges, then you're going to cause a big leak of spinal fluid and have a big risk of headache. So what you do over time is you design a needle that has not a cutting tip, but a tip which is supposed to just gently part the layers of dura, allowing them to snap back together once you've removed it. And they tend to have, for that reason, because they're not so sharp, this is a Quinky tip, which is a cutting tip. We don't use these. We tend to use these needles, Sprott's and Whittaker's, which are both pencil point needles and have a side port to inject the local anaesthetic. So our spinals have a definitive endpoint. With a small needle, we deliberately pierce the dura, we put half a teaspoon of local anaesthetic in. It acts very quickly, and as you will have all seen, the effects are almost instant. Most women will say that they can feel a difference as the local anaesthetic's going in terms of warmness and tingling in sacral regions, and that very rapidly progresses, usually to a block to about the level of T4. A block which we test usually with cold, because the temperature sensation is carried in the same nerve pathways as pain. Once we're happy with our quality of our anaesthesia, then we proceed, and the patient usually feels relatively little in terms of non-painful stimulation. So they may still feel some touch and stretch sensation, but it's not generally too intense. Now, our epidural, as I mentioned, involves passing a catheter. That's the epidural catheter above there, above the needle. So I'll use my pointer if I can. And in order to pass a decent-sized catheter, you've got to use a much bigger needle. So these needles, this is one you've probably seen before, is a 2E needle. It's 16 gauge, so it's equivalent to the size of the grey cannula that you'll be putting in a vein. The spinal needles I showed you before are as small as 27 gauge, which is even smaller than the smallest orange hypodermic needle. So there's a massive difference in the bore of the needle. And that's because we need to pass our epidural catheter into the epidural space. The downside being that the distance between entering the epidural space and entering the CSF can be as little as 1 or 2 millimetres. So just a small distance too far, and we'll end up piercing the dura with either our epidural needle or our catheter. Not the end of the world at the time. You can still provide analgesia or anaesthesia through it, but the problem comes afterwards when we look at the headache complications. Our epidurals, as you will have seen in your clinical practice, take a bit longer to work. That's not to say they take very long. If you get a move on and use the right drugs, you can generally, well, the fastest decision to delivery time using an epidural top-up I've ever seen is about 12 minutes, which isn't bad going. So it's not to say that necessarily it would be any faster or any slower than doing a general anaesthetic. But it does take a bit longer than a spinal to achieve the same levels of anaesthesia. And even when it does achieve the same levels of numbness in terms of thoracic dermatome testing, patients will often say that they feel a more intense level of non-painful stimulation with surgery under epidural top-up compared with your spinal anaesthesia. Now, of course, we can. So Kirsty mentioned that we can do combined spinal epidurals for labour analgesia. Perhaps doing this for surgical anaesthesia is our holy grail, or perhaps even our Harry Potter. What we can do is we can find the epidural space. This is for a cesarean section. We can find the epidural space. We can pass a longer spinal needle through the middle of our epidural needle into spinal fluid. We can give our spinal dose, which we get all the benefits of our spinal anaesthetic, but then we can pass our epidural catheter, meaning that if at 2 hours you're still requiring anaesthesia, you haven't run out of time, or even if your spinal isn't good enough and you need to top it up further, you've got your epidural catheter in situ. However, don't forget that if you were to do that routinely, which some units do, for every surgical episode, you're exposing the patient to the risk of dural puncture with a 2E needle, with a large gauge 2E needle, and its headache complications. When you didn't have to do that, you could have just done your spinal with your small spinal needle and its low headache complication rate. Kirsty's already mentioned some contraindications, and most of them are relative contraindications. Now, absolute contraindications include, of course, patient refusal to regional anaesthesia, although we do find that with adequate counselling, most patients will accept some form of regional anaesthesia, even if they're initially anxious about the thought. Other aspects that we need to think about include anticoagulation, and we are seeing an increasing number of our patients presenting to us on anticoagulation for various reasons. And of course, as Kirsty said, sepsis is a relative contraindication. It's often a clinical judgment in terms of the degree of sepsis, whether the patient has septic shock or whether they just have a mild systemic inflammatory response. So the downsides of regional anaesthesia. Many of you will have heard us talking to patients about these things, and many of them are fairly trivial. So most patients will get one or the other of a bit of shivering or itching. Almost everybody who has a regional anaesthetic for a caesarean section, with the exception of some patients who, for example, have existing hypertension or pregnancy-induced hypertension, will become hypotensive. That's because you're effectively performing a sympathectomy. You're completely taking away the sympathetic outflow, which is supplying the constriction effect on your lower limb and abdomen blood vessels. They're completely unable to constrict anymore. They relax, and therefore blood pressure drops. So every patient under regional anaesthesia will require a drug of some description to take over that effect. That's just, I wouldn't even say it's a complication, it's an expected effect. Moderately serious complications, failure and intraoperative discomfort. I tell my patients about 1 in 20 of them will get some degree of intraoperative discomfort, even if the block looks like it's working perfectly. There seems to be not an awful lot you can do to predict that, but I reassure them that the vast majority of them will need little more than some extra analgesia or sedation, and only a few of those patients will require conversion to general anaesthesia. Nerve injury sounds scary. The vast majority of them are not serious. So 1 in 1,000 or so patients will get some paresthesia or numbness after an episode of regional anaesthesia, most of which are short-lived. Even less frequently, they'll get a motor effect, so a weak muscle unit. And usually these things get better with time. So it's not a reason for most patients to be worried. Headache we've discussed. Headache is much more common with an accidental dural puncture with a TUI needle during an epidural than it is with a purposeful dural puncture with a spinal needle. If you have a headache after a spinal, the vast majority of those patients will get better of their own accord, although some of them will end up needing an epidural blood patch. However, the majority of patients who get a large size puncture of their dura with an epidural needle will end up with such debilitating symptoms from their headache that they will end up needing treatment. And the only effective treatment is the epidural blood patch. Has anyone seen an epidural blood patch? Yeah, lots of you. Good. So literally taking some of the patient's own venous blood, injecting it into the epidural space, the effect being to increase the pressure in the epidural space and to hopefully form a clot over the leaking CSF. Severe problems are fortunately extremely rare. However, we do have to bear them in mind and have a high index of suspicion for them in our postnatal patients. Those include developing an abscess or hematoma as a consequence of a regional anaesthetic technique. And also, although this is extremely rare, it is well reported that some patients develop a severe arachnoiditis, so it's severe inflammatory response in their meninges. This has usually been put down to contamination of their regional medicine with skin prep, usually chlorhexidine. And it's if you wonder why your anaesthetists are so fussy about chlorhexidine, where it goes, when it goes, whether it gets on their gloves or equipment, that's why. Because these complications, although they're rare, can be catastrophic. So you'll be pleased to know I've come to just about the end of what I have to say about regional anaesthesia, or anaesthesia for caesarean sections. To summarise, I would say that there are lots of good reasons why we've moved predominantly to regional anaesthesia for safety, for pain relief, for maternal satisfaction. But it's not the end of the world by any means to have to do general anaesthesia, because we've got better at doing it safely. Just my final slide is a plea to please communicate with your obstetric anaesthetist. Although we occasionally are awkward and grumpy, we usually want the same thing as you. No, we always want the same thing as you. Always? Usually. So please keep us informed about problems that are before they happen. Please tell us what you need. And when I say that, you'll always get you'll get a less grumpy obstetric anaesthetist if you tell them what the nature of the problem is and how quickly you want to solve it, rather than just running to them and say, you have to do a general anaesthetic now. And please keep us informed of things that are changing. It's very difficult sometimes to, when you're focused on a clinical problem, to remember that other people need to know that you've just lost 2,000 mils of blood into a sucker. But sometimes, if we're preoccupied with other things, we won't always notice automatically. So please do keep us informed of things as they change. Thanks very much.